very common topic. So what I'm going to do is the initial part of my talk is going to be quite brief. I'm going to kind of just make sure all of us are on the same page, and then the management component of it, I will try and elaborate a little bit. But I can always keep it open for question and answers at the end. So when we talk about sleep disordered breathing, there is always a lot of confusion. What is sleep disordered breathing? What is obstructive sleep apnea? Is it the same? Is it different? And if it is different, then how is it different? So this slide kind of gives you an idea, the connection between the two. Obstructive sleep apnea is not like a single entity. It's a whole spectrum, and the whole spectrum falls under sleep disordered breathing. So if you see on this slide, on the left is the normal child whose upper airway is normal, and the extreme right is obstructive sleep apnea. And in between, there are many, many shades. For example, a child might just have snoring, and he might not have upper airway resistance. He might not have disturbed sleep. He might not have hypoxia in the night. And that's a primary snoring. Initially, we used to think primary snoring is very safe. But today we know even primary snoring is associated with some neurocognitive defects, but we will talk about that a little later. Then when you move over to the right a little bit, then you have something called as obstructive hypoventilation, where you have increasing resistance sufficient enough to produce increasing CO2, but not so much more as in hypoxic episodes. And moving up a little bit, this entity here, called the UARS, the upper airway resistance syndrome, this was actually first described by Professor from Stanford, Gillimino, Prof. Gillimino. He is no more, unfortunately. But he was the one who actually from Stanford described upper airway resistance syndrome in children, characterized very clearly on EEG changes. It's not something that we do on an everyday basis, but it's definitely an entity where there is increased upper airway resistance. There is no hypoxia. There is no degradation. There is no CO2 increase, and that's one kind of entity. And when you move to the extreme right is the obstructive sleep apnea, in which there is hypoxia, there is arousals, and a lot of issues with obstructive sleep apnea. So that's the spectrum of OSA. So what is the pathophysiology of OSA? In a nutshell, I would say this slide is absolutely important to understand. When we talk about obstructive sleep apnea, most of us think of adenoidal hypertrophy, and we say, hey, this is the main problem is adenoid hypertrophy, send him to an ENT and our job is done. Unfortunately, it doesn't work like that, because there is a fine interplay of two different pathophysiological things in obstructive sleep apnea, and that is anatomical factors in the upper airway along with neuromuscular tone. All of us, the upper airway is not supported by any bone at all, because it's completely a muscular organ, the upper airway. Even the hyoid bone, which is there, is a floating bone, and it is not rigid, and it doesn't give stability to the pharyngeal wall as such. And therefore, if you have any problem with your neuromuscular tone, for example, in neuromuscular diseases, etc., then what happens is the whole upper airway collapses a little bit, and that causes obstructive sleep apnea too. So there is always a combination of anatomical factors and neuromuscular factors. For example, even if you take two children with very similar adenoidal hypertrophy, the same age group, both children have same size of adenoids. One child might have obstructive sleep apnea, one child might not. And that depends on the neuromuscular tone in that particular child. So it's a fine interplay between the two. And that is something that we need to understand. It's not just one. And that brings us to this slide, some of the common things that we can think about. So anatomical, what do we say about anatomical? The structural things are, of course, the commonest thing in pediatrics, and especially so between 2 years and 7 years or 8 years is the adenoidal hypertrophy. Then you have children with craniofacial anomalies, children with hyperplasia, hypertrophy of cervical lymph node tissue, etc., or nasal obstruction. Children with neuromuscular dysfunction, we spoke about them. Congenital or acquired, let me reduce. Yeah. Congenital or acquired muscle hypertonia and hypotonia. and also central problems like CCHS, or congenital central hypoventilation syndrome. Obesity, I'm sure, is catching up everywhere, including India. It's a contrast between both malnutrition and, of course, obesity is a type of malnutrition anyway. So, yes, there is significant obesity in pediatrics and even in India, and obesity is associated with obstructive sleep apnea, and the mechanisms are many. Not just structural, but even things like which have significant inflammation as a component of it. Rhinosinusitis, asthma, nasal polyps, increased systemic inflammatory markers, all of them contribute to obstructive sleep apnea. It's funny because obstructive sleep apnea also, as of today, is considered as a pro-inflammatory condition. And people have started diagnosing obstructive sleep apnea by doing very high sensitive CRP in certain populations. So there's a big interplay between which came first, whether the inflammatory parameters which I have suggested here came first, or it is all the form of a same syndrome where it is causing it as well. Uh, so when we talk about how do you diagnose children with obstructive sleep apnea, obviously the first step is taking a good history, and nothing to replace a good history, whatever investigations you have. And this page is not specific to obstructive sleep apnea. I thought I'll take the advantage of presenting this bears questionnaire, which is a screening questionnaire which most pediatricians should be asking parents, if time allows, to ask the 5 things about sleep. Whether the child has any bedtime problems, is the child afraid to go to sleep, or is the child not sleeping at time when he goes to sleep, etc. Or is there a history of excessive daytime sleepiness in this kid? A is for awakening in the night. Once he sleeps, does he have a continuous sleep, or does he keep waking up in the night? Is there a regularity of sleep cycle, meaning the teenagers especially? Are they sleeping at 1 o'clock in the one day and 10 o'clock another day? Weekends is different than weekdays. All of these are terrible things to do, which our teenagers unfortunately end up doing. So we need to take a history. And last but not least is the snoring, which we are going to concentrate today. So I think bears is something that it'll be good for most pediatricians to ask their patients, irrespective of whether they come to you with sleep problems or not. So when you talk about, particularly about obstructive sleep apnea, what are the different things we speak about? We speak about snoring. Snoring is a common thing that children have. If you take children with, sorry, I think there's an auto. Okay, snoring is very, very common in pediatrics. If you take children between 2 years and 12 years, almost 25 to 28% of kids worldwide have snoring at some time or the other. The mother will tell you, yes, he snores on a few days. Yes, he snores when he is tired. Yes, he snores when he has a cold, etc. So those are definitely there. But if you ask a little bit more, you need to ask how many days in a week does he snore? And if the mother says consistently he snores more than 3 nights in a week or 4 nights in a week, those are called habitual snorers. And those are the ones which are problematic. Out of all the children who snore, only about 3 to 4% have obstructive sleep apnea, which means the problem issue. And that is where the challenge is. How do you diagnose kids with OSA who have snoring? Witnessed apnea is common. When I demonstrate snoring to parents, I show them 2 types of snoring. One is I show them that is one type of snoring. The other type of snoring I show them is I show them that. And usually the mother will say, my child doesn't do this, the dad does that, or something like that. But basically, if the parents have seen that kind of witnessed apneas, it is more diagnostic of obstructive sleep apnea. Labored breathing children, mothers will tell you that the child is struggling to breathe in the night, and that's an issue. Children can be very restless. So normally when we say obstructive sleep apnea, The children are restless in the bed. They keep moving around all over the bed, and that's a feature. Enuresis, nocturnal enuresis. I wouldn't say all children with nocturnal enuresis have OSA, but children with OSA have an increased incidence of nocturnal enuresis. And children sleep with their neck hyperextended. So if the parents tell you that the child always sleeps with the neck hyperextended, one of the reasons is obstructive sleep apnea. Gastroesophageal reflux can do that too. Parasomnias also are increased in children with obstructive sleep apnea. When I say parasomnias, I'm talking about sleep talking, sleepwalking, bruxism, or grinding of teeth. All of them are nocturnal symptoms. Okay, so let's come now to the daytime symptoms. So when we talk about daytime symptoms, difficulty in waking up in the morning is a usual problem. Morning headaches, children will complain to you that they have headache in the morning when they wake up, and dry mouth, daytime somnolence, which means increasing sleep in the daytime. This, I would say, is a little bit of a caveat here, in the sense, if you talk about obstructive sleep apnea in an adult, the commonest daytime symptom is increased daytime sleepiness, right? In pediatrics, only a segment of children, for example, children with obesity who have obstructive sleep apnea, demonstrate increasing daytime somnolence, whereas other children with just purely adenoidal hypertrophy are opposite. They are hyperactive and they have poor attention. So they don't sleep in the daytime, but they don't know what to do because they haven't slept in the night, and therefore they are hyperactive all the time. So if you look at a lot of children with ADHD, diagnosed ADHD, etc., then it's quite a significant portion of them will have some sleep issues associated with it. And you ask also for poor social school performance, and that's one of the causes for that is OSA. Growth delay is definitely known, but it's very difficult to prospectively diagnose obstructive sleep apnea purely by growth delay. In a country like ours, growth failure can be because of so many other main issues. And the only way people have proved growth failure in OSA is after you have treated OSA, for example, adenotonsillectomy, children seem to grow better. So that's the only thing that you can say, right? So what are the monitoring tools? There are many monitoring tools. The most common monitoring tool that we have is history and physical examination. I've told you about the history, but unfortunately, even in the best of history and the best of questionnaires, formatted questionnaires, it's almost impossible to diagnose children with obstructive sleep apnea of all children who are snoring. So yeah, it's a big disappointment that while history is important, it's not enough to diagnose children with OSA. And that brings us to many other tools, the smartphone, video and audio recordings. I'm sure your parents must be recording their child in their sleep while they snore, etc., and then bring it to you. Unfortunately, it is not evidence-based as of today. And if you see a child with witnessed apneas and they brought it to you, and if you have already seen it and the history is suggestive, it's good. But if you see a negative recording, that doesn't necessarily mean the child doesn't have OSA. So what we are going to discuss today is two main things that we can do in practice. One is pulse oximetry and the overnight polysomnography. Pulse oximetry is something all pediatricians have access to. And if I know from Dr. Agarwal, you have a wonderful set of pediatricians practicing together and in a good hospital with a lot of facilities, and pulse oximetry is certainly part of it. You all know it is easy to perform, and there are some pulse oximetries which usually come with automatic analysis, and those are the ones that I will show you what it can do a little later. I'm sure you all realize it is relatively inexpensive. With the onset of COVID, I'm sure the prices of pulse oximeters, especially the finger oximetries, have dropped quite significantly. Even pulse oximeters that we use for our overnight pulse oximetry, which I will show you, have also dropped in price quite a lot. It's not, I wouldn't say it is cheap. I think the last I checked, it had dropped about 2,000 Sing dollars, which is about a lakh of rupees. in Singapore. I'm sure that will be much cheaper in India. When they always come to Singapore, they jack the prices up by two times or three times. So in India, it must be available for 40, 50,000 rupees. Diagnostic, if it is positive, which means if you do a overnight pulse oximetry in a child. See, the pulse oximetry that we are talking about is not a spot check pulse oximetry. We are talking about connecting the pulse ox to the child and leaving it overnight to record completely. And again, here it is important to know that it is virtually impossible for you and me to keep monitoring the monitor all through the night, irrespective of how good your hospital is and how good your nursing is. It's impossible to do that. And therefore, today there are softwares available which kind of record beat to beat whole night, and then it's easier to analyze in the morning. um, and if you show that this child has significant hypoxia in the night, then it is definitely indicative of obstructive sleep apnea, and you don't need to do anything else. You can straight away go and treat the kid. But if you have a normal pulse oximetry, it does not exclude obstructive sleep apnea. So we saw previously how OSA is a spectrum. Only the extreme component of it has hypoxia. So if you don't have a hypoxia documented, you can still fall into the lesser severe spectrum, which also has significant morbidity in children. So you cannot rule that out. Pulse oximetry, unfortunately, only shows desaturation. It doesn't tell you whether it is obstructive sleep apnea or central apnea. Both of them, as you would have seen in your preterm babies, they can desaturate with central apneas. So you can only show desaturation. You can't differentiate between the two. So, as I said, spot checks are not useful. You have to do it with something with overnight recording. The one that I have shown here is the Massimo one that we tend to use. It's called the Radical 7, or the Radical 97 is the recent one. And they are available for the price that I told you, and they are extremely good. And the key thing also to understand is, even though all the pulse oximetries that we use in our ICUs almost make you believe that ting, 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 they keep beeping, you almost are led to believe that it is giving you beat to beat saturations. Unfortunately, it is not. It averages the last 10 to 15 seconds and gives you a number. So every 15 seconds, it gives you a number, and that number is an average of what the saturation was over the last 15 seconds. In obstructive sleep apnea, hypoxia is very, very transient. It drops for a few seconds and then goes back up. So if you use a long averaging ones, that is the normal pulse oximetry that we use, then you tend to miss hypoxic episodes in these normal saturation monitor. So we have to have saturation monitors which have averaging times between 2 to 6 seconds. And that actually picks up a lot of OSA, right? This is a sample report that we tend to get in our hospital. It tells you how much time the recording was done, how much time the child spent above 90%, 92%, 93%. You can have various filters that you want to look at for your child, and you will be able to analyze it with a click of a button in the morning. And it is much, much simpler to diagnose things. People have actually come up with a lot of criteria. I'm just throwing it up because this is not gold standard. This is one of the good ones that is available in the world. This is called the McGill's criteria. Having done the overnight saturation monitoring study, people have standardized that. And if you use this criteria and all of these parameters are fixed, you can safely diagnose obstructive sleep apnea in children. People have gone on to modify this McGill's criteria to define mild, moderate, and severe OSA, but I think that was a little bit, that is pushing a little bit. But I would say, if you hold on to McGill's criteria, that's probably good. But oximetry, as I've told you, there are many limitations. It also depends on pulsatile blood flow, and therefore, if there is a vasoconstriction or hypotensive episodes, then you might not get. Movement artifacts are very common, but some of these pulse oximetries I showed you, like the Massimo, do have a software to kind of take away the movement artifacts to some extent. Changes in hemoglobin structure. So if you have, so the pulse oximetry is based on the fact that absorption of oxyhemoglobin and deoxyhemoglobin is different. But instead of normal oxy and deoxyhemoglobin, somebody has methemoglobin or carboxyhemoglobin. then the saturation monitor will not be able to help you. I've already said that. So that brings us to something called the gold standard, which is the polysomnography or the overnight sleep study. These studies in adults can be done both at home and in the hospital. Unfortunately, in pediatrics, home studies are not evidence-based. There are many companies who will come and talk to you to do home sleep studies in adolescents and older children. Please don't succumb to it because none of them are evidence-based. So hospital-based technician-monitored studies are preferred, and that is where the problems are. So what are the channels we routinely monitor? We monitor many channels. I'm just going to show you a table. We monitor the EEG for sleep. So we monitor EEG, we monitor oscillogram to look at REM sleep. We monitor the ECG, we monitor airflow, respiratory effort. We monitor whether the chest is moving and the abdomen is moving. We look at oxygen saturation and we look at carbon dioxide. So we look at a whole lot of things. All of them are simultaneously monitored and they get recorded overnight when the child is sleeping. And the technician is always there to put up the leads if the leads come out. And the next day morning, the child wakes up and goes home. And then the doctor is set to do the reporting, which takes quite a lot of time. This is how a typical child with sleep study will look like. Parents initially feel whether their child might be able to take it. Luckily, most children, if the technician is good and child friendly, you should be able to get it in most children. So what are the indications that I'm saying? It's not that every child with snoring needs a pulse oximetry. If you have a child in the proper age group between 2 to 12 who has significant OSA symptoms like snoring, witnessed apneas, etc., and if you look into the child and the child has significant adenoidal or tonsillar hypertrophy, then I don't think you need to waste resources by doing a sleep study for this kid. This kid can safely be referred to ENT, and if the ENT is convinced that there is an adenoidal hypertrophy, they would go ahead and do surgery. Then when is PSG indicated, or polysomnography indicated? It's evaluation of children with suspected OSA, especially those with high risk. So if you have children who have obesity, who have craniofacial syndromes, who have neuromuscular diseases of various types, these kids definitely need a sleep study if possible. When there is a huge discrepancy between symptoms and signs, for example, the child has significant snoring, and when you look into the tonsils are so small they don't even peep out of the pillars, and there's something wrong, then these kids, you have to be suspicious there's a problem. Also, if you have a child in whom, if you operate, the post-operative complications are going to be high for the conditions that I have stated here, then instead of just going ahead with surgery, you want to be sure that it is surely OSA before you operate. And therefore, those kids, this is kind of, I would say, this is a gray area for indication when you are resource crunched. If you have the resources, then I think this is a good thing to do. This is something that I'm going to talk to you about later. Symptoms persistence after surgery, if that is there, then PSG is a good thing to have. Apart from OSA, it is also good for evaluation of children with neuromuscular diseases. In our unit, all children with Duchenne's muscular dystrophy or spinal muscular atrophy who are on long-term follow-up, they all get periodical sleep study done to show hypoventilation or hypoxia at night. Children with congenital hyperventilation syndrome. Suppose you think of a child with, uh, Ondine's curse or something, then basically you have to prove it by a overnight sleep study. Evaluation of children with narcolepsy, excessive daytime sleepiness, that needs a good PSG to document that. For sleep-related seizures in the night, rarely I think it's underdiagnosed condition called the restless leg syndrome. We think it is only adult based, but pediatrics has a significant population. Not all children with restless leg syndrome need a sleep study. The common thing that we do is, if you suspect restless leg syndrome, you would subject them to a blood test and look at ferritin levels. If you have iron deficiency, treat iron deficiency, and restless leg seems to get better. But if not, and if there is refractory RLS, then a sleep study is useful to have. So what are we looking for when we look at sleep study? We look whether there is central apnea or whether there is obstructive apnea. So if there is no airflow coming from the nose and the chest is not moving, obviously it is central apnea. When there is no airflow coming from the nose, but the chest continues to move, then it is obstructive apnea. So it is very, very simple to differentiate, and a sleep study will show that. What is also important, which we cannot see with naked eye, is something called hypopnea. Hypopnea means there is not an absence of flow from the nose. It's not complete apnea, but there is a drop in amount of air coming out of the nose by 30%. And that is associated with either a desaturation or an arousal. And that is what we call as hypopnea. So when we look at children for obstructive sleep apnea, we do not look at the amount of central apneas that these children have. We do not score them. We only look at obstructive apneas and hypopneas. And based on that, we come up with a criteria. And that is OAHI is nothing but obstructive apnea hypopneas index, which means you count all the obstructive apneas, all the hypopneas, you then divide it by the total number of hours of sleep that the child has. You will get a number that is the number of events that the child has per hour. If the child is normal, it has to be less than 1. 1 to 5, it's called mild. 5 to 10, moderate. More than 10, it is called severe obstructive sleep apnea. This is how a typical child with obstructive sleep apnea will look like. This is the saturation. You can see the saturation is going to 98, dropping to 91, 97, 98, dropping to 93. So that is because this is the airflow. You can see the air is coming out of the nose and going back in. Here, suddenly there is absence of air coming out of the nose. But if you see, the chest continues to move. So there is movement of chest, but there is no movement of air from the nose. This is classical obstructive sleep apnea, and that is what you measure in polysomnography. Is it foolproof? Is it 100%? No, it has its limitations. Availability is an issue all over the world. Cost is a huge issue. It's pretty expensive. It is very, very technician intensive. When I was in India, even in Singapore, we have problems with getting the right technician and to stay with you for long. Otherwise, you train them and then they go away. So that's a huge problem. It is very time intensive. All pediatricians are busy, and you see, if you're a even if you're a pediatrician who sees one patient every 10 to 15 minutes, you still see about 4 or 5 patients an hour. Each sleep study will take about 1 hour to 1.5 hours for you to read, and it is not paying. So for those of you who think sleep studies are fancy, you can make money from it. Unfortunately, it is not. It is very, very time intensive. So you really have to be passionate for you to start doing it at that time. There's also sparse data as normality, and therefore we need to keep going. And the problem with polysomnography is it only tells you there is OSA or not, or not. It doesn't tell you if there are. It doesn't tell you if there are morbidity because of OSA in these children. Okay, so let's look at quickly now the management guidelines that we look at. If first we will see at obstructive sleep apnea in normal children. So all of us know when you have a child with obstructive sleep apnea in the age group that we see, we always think, oh, it is adenotonsillar hypertrophy. We send it for ENT for adenotonsillectomy. And that is not something new. It is not very new science. If you see in 1889, this person called William Hill, he was an anatomist. And I guess at that time, anatomists actually saw children too. And basically, if you see what he has written in 1889, it is not uncommon to find children who suffer from deafness, result of enlargement of tonsillar or lymphoid tissues of the nasopharynx, described by their parents and teachers as being backward and even stupid. So he says he's not only recognized obstructive sleep apnea as a result of tonsillar hypertrophy, but he has also realized that it causes morbidity like deafness and cognitive problems. And he goes on to even say, have been struck by the fact that operations in children undertaken for relief of deafness associated to adenoid growths and enlarged tonsils have resulted in such improvement in the mental acuity of patients. So way back 150 to 200 years back, this man has already clearly shown OSA has problems. OSA is because of adenoidal hypertrophy. You treat adenoidal hypertrophy, OSA goes away and the symptoms get better. So this is not new. And so everybody continued. And whenever people diagnose OSA, we used to send them to ENT, and ENT did an adenoidal tonsillectomy. It was only in 2000 that David Gozal and team started noticing that not all children who got adenoidal tonsillar hypertrophy got better. In their first meta-analysis of retrospective study, they found that about 80% got better, 20% had residual problems. That was the first thing. So he was quite intrigued and he did a prospective study. In his prospective study, he showed that only 25% of children became normal after adenoidal tonsillectomy. That means 75% continued to have residual problems. And children with obesity and severe OSA are the ones who had more issues, right? So many studies kept coming up which showed very similar results. I'm going to show you one study which was wonderful. It is being done in Taiwan, which is a prospective study in children between 6 to 12 years. And what they did was, you and me have problem doing one sleep study. These people kept doing sleep studies before surgery, 6, 12, 24, 36 months after surgery. And what did they show? I will show you for lack of time. I will show you that their OAHI, the mean was 13.4 before surgery. After surgery, you can see most children improved. There was a significant number of children who improved, and the OAHI mean came down from 13.5 to 3.47. And about 46% of children completely got better, less than one. Okay. But if the same kids were seen for the next 3 years, even children who had normalized after surgery started recurring problem by 3 years of age. The OAHI went up to 6.48. So what I'm showing you here is adenoidal tonsillar hypertrophy surgery is, of course, it is useful, but it is not a complete thing on its own. So what are the high risk factors for residual OSA after surgery? Obesity, severe OSA before surgery, older children, children who have concomitant medical conditions like trisomy, craniofacial syndromes, and allergic rhinitis. So adenotonsillar hypertrophy is still the first line management, but you have to be careful when you do it. What is the role of CPAP? In children in who have very small adenoids and tonsils, in whom you don't think adenoid tonsillar hypertrophy is going to make a huge problem. Those who are not surgical candidates, I have spoken about them before, or for those in whom parents decline surgery, then CPAP is a good option. CPAP, when we do, we bring the children to the hospital first for the first few hours. We initiate them on CPAP. Children take a little while to get used to the pressure and the mask, and then we send them home with a simple CPAP. We bring them back, repeat a sleep study, what we call as titration sleep study, and prescribe the right pressure for each of these kids later on. So what are the advantages of CPAP? It improves respiratory parameters, no doubt. It improves the neurobehavioral sequelae. Children get better. You can see visually what the improvements. But there are limitations. It's very poor adherence. In adolescent population, less than 30% are adherent to CPAP over a long period of time. And therefore, it is a challenge. Even if you start it, it's a challenge to keep it on in children. Is there a role for medical therapy? I would say zero. But if you go by evidence-based medicine, there is a small role. It says you can use the medications, especially INS or intranasal steroids and montelukast, especially in children who have mild OSA, less than 5. Or if you have children I will wrap it up by going into some few things about children in special circumstances. Obesity, as I said, is a huge problem. And I said obesity actually produces slightly different symptoms. So obese kids have increasing sleep in the daytime rather than hyperactiveness. In children with obesity, CPAP, BIPAP is almost the first line. For example, just 2 days back in my clinic, I had a kid who was 11 years old. His BMI was 26. We did a sleep study because he had severe snoring. His OAHI was 47. So I have counseled the parents not only for going and getting an ENT check done to see if adenoid hypertrophy is there to get the tonsillectomy done. However, I've already initiated CPAP for that child because I think with that kind of severity and obesity, you are not going to have complete resolution of symptoms with surgery. Weight management, we all know how difficult it is, but we still need to persevere in those kids. Children with neuromuscular diseases, especially sleep disorders in children with neuromuscular diseases include obstructive sleep apnea, nocturnal hypoventilation. Their CO2 becomes really big problem in the night. And these children, we usually monitor them over time. As I said before, we do intermittent sleep studies on them, and if we show that these kids have a problem, then we start them on therapy. And usually in neuromuscular children, we don't start CPAP. We usually start them on BiPAP rather than CPAP. Even in these kids, if the adenoids and tonsillar size is huge, we do a tonsillectomy. That is because once you remove the anatomical obstruction, the pressure required for these children actually drops. So even though it doesn't cure it completely, I think it is still good. This child typifies a child with craniofacial disorders. And for these kids, adenotonsillar tonsillectomy is not an absolute solution. So you have to initiate them on positive airway pressure. So that will include, and not only positive airway pressure, but you would also subject them to craniofacial surgeries if you have a local surgeon who's able to offer that for you. Tracheostomy, we are getting away from tracheostomy more and more for these kind of issues. We do mandibular distraction surgery, etc., to avoid tracheostomy in these children. But that differs from center to center. Children with Down syndrome need a special mention because OSA is very common in children with Downs. There are many reasons why Down's children are more prone for obstructive sleep apnea. They have hypoplasia of midface or mandible. They have relative macroglossia. They have lingular tonsil hypertrophy. They can be obese. And there is also hypotonia and therefore decreased airway tone in these children. All of these things make them very prone to have OSA. In fact, the American Sleep Academy now suggests that all children with Downs or trisomy 21 should have a sleep test done before the age of 2 years. Early screening is required. And if you find that these children have adenoid tonsillar hypertrophy, then surgery is probably the first step. But don't be shy to start them on positive airway pressure if there is perseverance of symptoms even after surgery. Okay. So in children who have obstructive sleep apnea after adenoid tonsillectomy, not all of them need therapy. Some of them, if it is very mild symptoms, there is a role for medical therapy, as I had said before. Nowadays, if you look at literature, a lot of people are doing what we call as DICE, which is drug-induced sleep endoscopy, which means they put their child under anesthesia and then try during anesthesia they do endoscope and see which part of the airway is getting obstructed in sleep, and then they do a targeted surgery for that. You can initiate positive airway pressure therapy if the child has severe obstructive sleep apnea after you have treated them for adenoid tonsillectomy. Okay. So in summary, what have I said? I've said understanding pathophysiology is important for personalized treatment plan. So you need to know what is the cause in this kid. Not all of them are just adenoids and tonsils. And once you know what are the underlying things, then you can, I have shown you how you can vary the treatment between different groups. For normal children with OSA, adenoidotonsillectomy is still the first choice of management. And be aware that you can have residual obstructive sleep apnea even after you have subjected them to adenoidotonsillectomy. Thank you. I'm quite happy to take questions if there is time.
Thank you, Mahesh, for a wonderful deliberation. Uh, I would rate this as one of the very best lectures on our platform. And if there are any questions, most welcome to ask.
Mahesh, if I can ask a question, we are saddled with the problem that sleep study is unavailable in our city for children. There are some adult medicine experts who are doing sleep study in adults, but for children it's not available. And even if it were to be available, then most of the patients, I would say 99%, would not be able to afford the study. We have been thinking of surrogate markers of obstructive sleep apnea. One of them, as you rightly said, is the history of beautifully demonstrated that. I think we should take a video of that demonstration to show to the parents what exactly is an apnea during sleep. Apart from that, I was wondering, all these patients will have some degree of hypercapnia. Just because before they get up in the morning, if we can have some way we can by which we can measure PCO2, will that be a good surrogate marker?
Unfortunately, no. The hypercapnia which occurs in this is not persistent. So just when there is a dip in hypoxia, there is a relative hypercapnia, and then it disappears. Once the child recovers and breathes well, he disappears. There is a small segment of children who have persistent hypercapnia. We call them as obstructive sleep apnea with hypoventilation. But even that is defined as CO2 greater than 50 for more than 25% of the sleep time. The definitions are very different. So the ones that you are saying, we used to do it initially for neuromuscular children, because if kids don't sleep very well in the night, for which is 8 to 9 hours a day, what happens is they start in their blood gas. So if you do a CBG or an ABG in daytime, and you show that their base excess is more than +5, then there is a high chance that this child has probably got overnight. But this is not for OSA. This is for children with neuromuscular defects. So I'm talking about different population. So for OSA, for the population that you are saying, unfortunately, no. There are quite a few things that people are trying. People are trying looking at metabolic things, high CRP, high ESR. People have shown some results there. People are doing urinary metabolites and exhaled breath metabolites. Unfortunately, not for clinical parameters at this clinical practice at this point of time.
Very few of our patients get operated. What are the long-term consequences? Most of them are not getting operated. What is happening to them in the long run?
So I just want to share. There's a professor called Chris O'Callaghan. I'm sure. I hope he's not listening, because this is on the line. I have no idea whether he's listening or not. He is the professor right now. He's moved to Get Almond Street. He was in Leicester. He came to Singapore just about 4 years back, and we were talking. And he said to me, Mahesh, you're all doing all these sleep studies. Do you think in our times we sent all idiots home? So Britishers are they are quite behind the Australians and Americans as far as sleep medicine goes. So he also said, what's the big deal in sleep study? You're not actually but if you look at literature, the long-term consequences in terms of cognition, in terms of learning behaviors is tremendous, and children are affected surely by obstructive sleep apnea. So even though parents might not realize it, they might just think, oh, my child just gets 60% in school. That's fine. He is passing. But maybe if you treat his obstructive sleep apnea, he's a kid who can get 65 to 70%, and he's just dropped a few points because of OSA.
And what about its effect on pulmonary hypertension and long-term hypertension,
Yes,
systemic
that
hypertension?
is there, but I didn't want to sound too negative, but it is definitely there. But those are things that you and me might not see in a clinical practice at that point of time. You will see them with over time. If you look at all the studies of pulmonary hypertension, not only pulmonary hypertension, they have shown pulmonary hypertension, systemic hypertension, endothelial dysfunction, left ventricular remodeling. So you can, if you are good in doing echoes, you can show that children with obstructive sleep apnea have slightly enlarged left ventricle and hypertrophy of the left ventricular wall. So everything has been shown, and surely it has a long-term problem on all of these parameters. Yes.
No,
There's one question on the chat box. I think you have already alluded to that, but Dr. Khurana wants you to elaborate on overnight pulse oximeter assessment using Masimo pulse oximeter.
Okay.
And is
So-
the equipment offered on loan for monitoring at home?
I am pretty sure in India there will be somebody who is genuineness to start doing that. I don't know that. You must be telling me. I don't know that, but I know there are so many things. My cousin just went abroad for wildlife thing, and he rented a telephoto lens for 400 rupees a day. Came back and gave it back. So I was surprised how people rent things for fantastic business people do. So I'm sure it's available. I'm not sure. What you need to definitely understand is you need to understand the limitations of of what we have. So you cannot use your routine pulse oximeter for doing it. You need to have the right monitoring device, which I showed you. It has to have recording facility overnight. It has to have a short averaging time for you to pick up hypoxic episodes in these kids.
And then, as Girish has pointed out, limitations of resources and availability of the investigation. Similarly, is with most of the practicing pediatrician is assessment of the adenoid and the tonsillar size. Would you pass on some practical tips as to which you would say as really enlarged and is going to benefit by surgery?
Okay, so here, this is yes, I can see the thing is the adenoidal hypertrophy has got 4 grades, right? So basically, you can say 1 plus, 2 plus, 3 plus, 4 plus. 1 plus is where if you see the tonsils just outside the pillar. 2 plus is it's midway between, or it is less than midway between the center point and the tonsillar pillar. So I would say anything from stage 3 to stage 4, which means if the tonsils are so big that they are almost kissing tonsils or almost touching the midline, those are the ones who will definitely require surgery. But having said that, I am a strong proponent of saying tonsillar and adenoidal size and severity of OSA do not go hand in hand. Because as I said before, it depends on neuromuscular tone of that kid as well. And therefore, the old days of doing a lateral neck X-ray to see for adenoidal size doesn't really hold true. You can have a child who has a big adenoid and no OSA. You can have a child in whom the adenoid size is very small, but even that small adenoid is actually causing OSA to him. Therefore, I would say it is not a very good parameter. But if you have a strong history and you show some adenoidal hypertrophy, and in the absence of investigations, then I think those are children with. So I would lay a stress on history along with his physical examination to send to for surgery. I would definitely indicate that. Yeah.
One question, you have been talking about tonsillar size. Is there never a dichotomy between tonsillar size and adenoidal size?
Um, I asked this to Prof. Gilimina when he came to Singapore. I asked him because it was a practice in Bangalore at least that they do mainly tonsillectomy without adenoidectomy, or they do adenoidectomy without tonsillectomy. When you come out of India, nobody does in singular. It always is a combination of adenoids along with tonsils most often. So I asked him, is there a role for it? And he said, the major problem is adenoids rather than tonsils. Nobody has correlated the size between the two, but out of the two, the tonsils as such do not have a major role in OSA, and it's mainly the adenoidal size.
No, no. What I'm asking about is, as a pediatrician, I can only comment on the tonsillar size, not on the adenoidal size. I have to send to an ENT chart. So can I send only those patients who have significant tonsillar hypertrophy for evaluation to an ENT surgeon?
I guess that's the best you and me have. Yes, if you have significant symptoms and if you are in the right age group between 2 to 8 years when lymphoid growth is maximum, you have documented one lymphoid tissue which is huge. You are assuming that the other one is also going to be big because of which he's having symptoms, and therefore you are right in sending. Yeah, you're right.
So in the absence of these investigations, there are two rules that I follow. If there is definite history suggestive of apnea, or there is perennial snoring, because many of the snoring is seasonal, during winter months when they have recurrent URI. If there is perennial snoring with definitely enlarged tonsils, I refer them for surgery in the absence of investigations. Would you like to comment on this?
Absolutely correct. That's what even I said. You don't need investigations for all of these kids. So in the exact population that you have described, you can send them directly for surgery without any investigations. So I would say the severe ones, you and me might be able to pick it up as good pediatricians. It's the subtler ones or those with high risk who might not have the typical symptoms. And those are the kids we need more tests to be done.
It is my feeling that ENT surgeons overdiagnose and pediatricians underdiagnose obstructive sleep apnea.
You're right. I have always made fun of my ENT surgeons that they move from village to village after finishing adenotonsillectomies in one village. When they have cleared the adenoids in one village, they go to the next. But that jokes apart, I have also had situations where pediatricians have told me, Mahesh, is so frustrating. We diagnose OSA and send it to the ENT. ENT says nothing to be done, just gives them INS and sends them home. So both are true. Just because my pediatrician colleague said so, I wouldn't agree. I would say, no, you try intranasal steroids for some time, you'll be okay. So both are true, but you're right.
Okay. If there are any more questions, you are most welcome to ask anybody.
So I would say OSA is, in India, if you have good clinical acumen and a good history, you should be able to pick up a significant number of children. We don't have to feel bad that we don't have. In fact, all of us are looking for alternatives. And my aim, honest aim, is to get something that will benefit our country with low cost home monitoring for sleep apnea. And I have been trying this in various forums. Right from the time I came to Singapore, I've been working. Unfortunately, it gets shot down every time. But right now also, we have a grant which has been proposed. We have gone through 2 hoops. We are in the final stage. If it comes up, it will be good. So we are looking at having skin sensors, which can pick up airway, airflow, which can pick up saturation, which can pick up heart rate variability. And these are skin sensors which you stick on the skin and the child will not even know, or you put it on the vest or the bunion, so that it just moves, and it's a fabric which contains the sensors, and it shows you thoracic and abdominal movements. So we are integrating all this wirelessly, so there is no wire at all that the kid has to grapple with or he can take off. So that's the latest one that we are thinking about. So hopefully, if not this grant, if not me, somebody will come up with something which we all can use in pediatrics in India.
Somebody has asked any effect of various pranayams on sleep apnea in children or adults.
I can't think of anybody doing pranayam in the night. So when it is happening, when if it's a problem of obstructiveness in the daytime in a child with say, for example, anatomical problems like obesity or craniofacial syndromes, I can see how pranayam and modulating your breath, increasing the depth and rate of respiration can actually make it better. People have shown that airflow can change from turbulent airflow to laminar airflow when you do good pranayam. So in awake state, when you are doing pranayam, it helps. But I am not aware of studies which have shown the after effects of pranayam in the night. That is, you do pranayam in the day, your nighttime is good. I haven't seen any results on that. So I think that's a difficulty.
Mahesh, yesterday I had a child in my clinic, 12-year-old. The main complaint of the mother was that the child sleeps for around 11 to 12 hours in the night. And any time during the daytime, he can go off to sleep very quickly into deep sleep. And there is no history suggestive of any snoring or apnea. So what exactly should be done for such a child?
How old is this child?
12 year.
12 years. Okay. So this is hypersomnia. So basically, if you look at all children who have increasing daytime sleepiness, almost 60% of them have abnormal sleep in the night. So either the quantity of sleep in the night is not good in teenagers, but in your case, it is not, or the quality of sleep is not good in the night, which means even though he sleeps for 11 hours, maybe he is not able to get into good deep sleep in the night. That is the commonest problem. So the first thing that I would do for such a kid is to give them, you will find a lot of these sleep logs available on the net. Otherwise, I can send a template across to you what we use. It just is a nice, good one Excel sheet kind of paper in which the parent just mark what time in the night they go to sleep, what time in the morning they get up, and in the daytime, if they sleep, when they sleep, kind of thing. So over 14 days, they maintain a log. You'll be surprised what parents say and what actualities are completely different. So I think the first thing I would do is to get a sleep log, document that the child's sleeping quantity wise is good. If the quantity is good, then it depends on whether the quality is good or not. That unfortunately requires some kind of investigation, which I have told you. And if that is also good, then this kid likely can fall into one of those hypersomnia episodes, which is either narcolepsy, which is calm, which starts around second decade. 12 years is a little too early for that, but we can have, or idiopathic hypersomnia, which means children can have significant. So the way we diagnose them would be to do daytime sleep study called the MSLT, or we do me. What we do is we do an overnight study. The next day morning when they wake up, we get them an opportunity to sleep in the daytime in the lab itself every 2 hours. So wake them up, we give them breakfast. 7 o'clock they woke up, we give them breakfast. 9 o'clock we say, okay, it's time for you to sleep. We give them only 20 minutes to sleep, and then we wake them up again. Every 2 hours we get them to sleep. And then there is a evidence to say if your mean sleep time is less than 8 minutes for every time you go to sleep, that's suggestive of hypersomnia. Then you need to treat them. But that is the advanced. So before going there, I would say the basic thing would be a sleep log and trying to look at the quality of sleep in the night.
Thank you so much.
Mahesh, can you tell us how many hours of sleep a normal individual needs in his lifetime? That is at various ages, 50 to 60, how many hours we should be sleeping?
We would probably, our age group, we should be sleeping between, I think, 7 hours to 9 hours. 6.5, 7 hours to 9 hours is what ideal for adults. Uh, I know as pediatricians, a lot of us might not get that, but there is a big, see, I always, this is my pet topic of saying we don't know what the exact number of hours is. Because all these numbers are all coming from the Americans. The Americans' way of life, American sleep habits are very different. We did a preschool children study in children less than 3, and we found that Americans and all Caucasians, including New Zealand, Australia, they sleep at 7 o'clock. These, I'm talking about preschool children, okay? They sleep at 7 p.m. and get up at 7 a.m. or 7:30 a.m. Japanese kids sleep at 10:30 p.m. and get up at 6 a.m. So there's a huge difference of 2.5 hours of sleep between the Caucasian kids and the Asian kids in extremes. Singapore falls somewhere in the spectrum. India falls somewhere in the spectrum. All of these we have done. But what I'm trying to say is it doesn't make Japanese any less intelligent. It doesn't make Indians any less intelligent. So we don't have exact norms, if you like, of our own as of now. So we are depending on the American norms, but it has to be taken in context.
Thank you.
Thank you so much. Thanks, Mahesh, a lot. I mean,
Thank you, sir.
I'm sure everybody who is on the platform has enjoyed your talk immensely. And thanks for your time and expertise. Thanks,
No problem.
Mahesh.
Thank you, sir. Thank you so much.
Yeah.
Thanks to all of
Thank
you.
you,
Thanks,
Mahesh.
Harish. And thanks to the whole team. Thank you, sir. Bye-bye.
Bye.